my professional career for last 25 to 30 years. I did my medical school in India, my residency in New Zealand, and my fellowship at MD Anderson Cancer Center. After my residency and fellowship, I stayed on the faculty of MD Anderson for about 10 years. Then I moved to California, and few years I was a co-director of Cancer Center at Cedars-Sinai and ran clinical trials for UCLA. For last 20 years, we have established this oncology center, which is Sarcoma Oncology Center. Mainly expertise includes sarcomas and new drug developments. I'm a clinical faculty at UCLA, USC, Cedars, St. John's, that's John Wayne Clinic, and City of Hope. I'm just clinical faculty. That means I collaborate with the doctors. I can access those records, and I collaborate various research programs and refer to the various experts in the field, including oncologists, surgeons, and other specialists. I'm going to give you a brief description of leiomyosarcoma treatment plans. I'm not going to be extensive about it. And most patients, the surgery, if the primary tumor is surgery, we do surgery. And you already know about that. If the tumor is localized, we give also radiation therapy or to control the local area, even if it is metastatic disease. To prevent, or if the patient has already metastatic disease, we give systemic therapy. That means it systemically goes. Previously, we had only chemotherapy, but in last few years, we have chemotherapy, we have targeted therapy, we have immunotherapy, we have cellular immunotherapy, and combination of above. The standard chemotherapy, which everybody knows about it, started Doxorubicin or Anamycin. It's a very good drug, but one thing you need to remember, people think it is very toxic. Yes, it is, but there are ways you can give it, make it less toxic. And unfortunately, not many doctors know as well, oncologists too, that if this drug is given slow infusion over 48 to 96 hours, then almost there is no heart toxicity. People worry about cardiac toxicity. In last 25, 30 years, I've not seen anybody with the heart problem. Only way you give is give slow infusion by continuous infusion over 2 to 4 days. Or you give weekly because it's the peak level, high levels, which cause cardiac toxicity. But do not avoid this drug. It is an active drug. The second drug is called ifosfamide. Again, it's an active drug. People think it's very toxic, but yes, if you give a big dosage over 2 hours, it is toxic. We give it slow infusion over 10 to 12 days. Outpatient, don't admit, and it's less toxic and still effective. The combination of doxorubicin and ifosfamide, most people refer AIM. Again, AIM is a good treatment, but should be given over 10 days to 2 weeks. Slow infusion will be less toxic, don't need to admit. Then the second treatment protocol came in about 2003 or 4 called Gemzar and Taxotere. Again, very toxic regimen, and given Gem day 1 and Taxotere and Gem day 8. It is very toxic. We have modified and we give lower doses of both Gemzar and Taxotere day 1 and day 8. And sometimes we add very, very low doses of Doxorubicin, we call GAT. And we have published that giving this way is substantially less toxic and more effective. So I don't use GEMS-R Taxotere regimen standard as described, but we use GAT day 1 and day 8, all 3 drugs. Third drug or fourth drug which came in 2012 worldwide and 2016 in this country is called Trabectogen. It's a very good drug derived from sea urchin, relatively non-toxic, does not cause hair loss, and all other toxicity are minimal. And by itself, it is reasonable. But if you add other drugs, PD-1 inhibitors, it is very effective. One good thing about this is also immune potentiating. That means it boosts the immune system with other drugs, and it can be given for a long time. So unlike Doxorubicin, where you can give only 6 to 10 cycles, this drug can be given for a long time. Then we came after, there's another drug called oral drug, and I'm honored to say that Trabectogen trial I did mainly and was responsible for approval in this country and worldwide. The other drug is called Pazopanib or Votrient. It's an oral drug, and I did the trial, and we were the highest enroller in the study. Also work, and it is available. Last drug is called DTIC or Dacarbazine. Again, relatively non-toxic drug, is very effective in some of the patients, and some patients are cured with this drug, does not cause hair loss, and does not cause any heart problem. And then one more drug which is not approved called Eribulin, and this was, we did the trial both Eribulin in liposarcoma and leiomyosarcoma. Some of the patients with leiomyosarcoma also had dramatic response, but the drug was only approved for liposarcoma. But if there are not much other option, Eribulin is reasonable to try for leiomyosarcoma. The clinical trials we have used some newer drugs and some other drugs. So the patients who never received any treatment frontline, we have a drug called Trillium antibody, which is a CD47 antibody. Cancer cells have an antigen CD47, and it mimicries like our own body and tells our immune system, don't eat me, I'm part of you. So it's mimickers like your own body. So we have made an antibody to CD47, and the name of the company is Trillium, and they are using with Doxorubicin as a frontline. That program just started, and the same drug is shown effective in number of leukemia and hematological cancer, and also being investigated in ovarian cancer. So that's one study frontline. Second drug, there is a drug called TNF, tumor necrosis factor. And they have linked this tumor necrosis factor to Doxorubicin. And so if anybody never got any treatment, we use Doxorubicin plus TNF together in leiomyosarcoma. Again, a patient has never received any treatment. The third drug is called Cancirubicin, C-A-N-S-C-I Rubicin, R-U-B-I-C-I-N. Cancirubicin, they have modified the actual molecule of Doxorubicin, and they claim that this is more effective and less toxic, and pretty much the heart side effect is not there. For this drug, again, for untreated patients. And so these are the 3 trials we have untreated patients. There is another trial, which is we call SOC 1701 or SAINT trial, SAINT trial. This is trial of my colleague, Dr. Arlinda Maria Gordon. And this includes frontline patients who did not get any treatment before, Trabectogen as a frontline, along with nivolumab or Opdivo, which is an immunotherapy, and ipilimumab. We have already treated about 75 patients with this regimen, and we think this is the best regimen. The control or PFS of disease is more than 10 months, while all other drugs, whether doxorubicin, ifosfamide, or AIM, is between 4 to 6 months. So these are the trial as a frontline. Patients who have failed number of treatment or whatever we get, the second line treatment is, there is a drug called Anamycin. Anamycin is developed by MD Anderson, again, analog of doxorubicin, does not seem to cause alopecia or heart problem, and seems to accumulate predominantly in the lung, although it goes all over the places. So the patients who have predominant lung disease, we will like to give them Anamycin. Patient could have any number of treatment as long as doxorubicin dose is less than 350 milligram per meter square. And we are seeing some encouraging results of that trial. The last other trial is called Sasky, Sasqui. This trial is only for patients who has a big disease, which we can palpate or we can inject by ultrasound guided or clinical or by CT guided by radiologist. We put a polymer in the tumor, and that activates the doxorubicin, which is a prodrug we give intravenously. And so the highest concentration of about 50 to 100 fold is activated in the tumor itself. The trial is going on, and there are more than 5 to 6 sites of the trial in the country. Similarly, for local control of the patients whom we can feel the tumor, or we can inject by ultrasound or by CT scan, this trial is called TNT, which T stands for Trabectogen, which is Yondalis, given intravenously day 1. N stands for nivolumab, which is Opdivo, which all of you know is immunotherapy intravenously. And last drug is TWAG, which is an immunotherapy with GM-CSF molecule attached to it and given in the lesion. All 3 drugs are approved for various reasons. As you know, Trabectogen for leiomyosarcoma and liposarcoma, nivolumab for 20 type of cancers, and last TWAG is for malignant melanoma. So all 3 drugs are approved for various conditions, but we are using for all sarcoma, including leiomyosarcoma. And we are going to present this paper in the upcoming CTOS, which is a Connective Tissue Oncology Society. Preliminary data are as good as any other standard treatment and relatively non-toxic. Trabectogen doesn't cause hair loss or other things except mild myelosuppression, and the other 2, TWAG, hardly any toxicity, and nivolumab in 90% safe, and less than 5 to 10% can cause immune reactions. And so this is called TNT trial. Then we had a trial with enlotinib, which sort of we are analyzing the results. The trial is complete. And then there is another trial called TAGGED, TAGGED, and this TAGGED trial is combination of Trabectogen, DTIC, and Gemza. So all 3 drugs are individually active in leiomyosarcoma. None of them cause hair loss, and we give in metronomic dosage. And this trial just started, so I can't speak how much efficacy, but toxicity is pretty much minimal. All these trials have been approved by a central IRB, and most insurance cover these trials. If they don't cover, I will take care of you free as long as the drug gets availed from the drug company or from the other places. And please feel free to call my office or including me. I'm going to give you my cell number, and please feel free to circulate this cell number. That's 310-500-5391. And my email address is Sant Chawla, my first name, last name, SANTCHA, Apple, WLA @gmail.com. And now I'm open for any questions you guys have. And again, I sincerely appreciate you giving me this opportunity to serve you guys. And I apologize for being late.
We have some questions in the chat box. If you can see that, Dr. Chawla, I'm not too sure.
I'm on my cell phone, so let me see.
Okay,
Can you
I'll
read
see if I
it
can
rather
read
than
them.
me? Yeah.
Yeah, one is, and I'll get to these folks. Anthony Reese wants to know, can Trabectogen be given by slow infusion?
The standard approval by FDA is 24-hour infusion, and that requires a central line. But if somebody does not have central line and doctor agrees, you can give 1/3 the dosage every week over 1 hour.
Okay, great. And I asked, so can you have Doxorubicin, have had Doxorubicin and still qualify for Anamycin?
Yes, as long as you had less than 350 milligram per meter square.
Okay, that would be hard for us to know what that is.
No, so what if you had more than 6 cycles, less than 6 cycles of Doxorubicin, you will still be eligible.
Okay, that helps. That helps. Can you discuss, and I'm really bad at these drug names, pembrolizumab?
Okay, pembrolizumab, and yep. Another name is Keytruda.
Okay.
It is called PD-1 inhibitor. It's a immunotherapy, and there are 5 drugs of this group. None of them are approved for leiomyosarcoma. They alone do not work, but we think they work with some chemotherapy, particularly Trabectogen.
Okay, great. Any more questions, folks?
There's 2 questions at the top. It says, could you please describe if you consider uterine and non-uterine LMS separate diseases, and why or why not?
All cancers are criminal in the body, and they commit different kinds of crime. And but they have a different sort of predilection. But whether it's uterine or non-uterine, they are pretty much behave similar. In females, 50% of leiomyosarcoma originate from uterus, while in the males, it can start anywhere else, and 50% of the female can originate. It's a tumor of the smooth muscles. In my opinion, they are not different. They are criminal. One starts in uterus, others start anywhere else. And they all respond to the similar, they have similar background, and pathologic diagnosis similar.
Okay, we have a question. How difficult is it for Canadians or other foreigners to attend, okay, it just moved on me, to attend trials at your clinic?
In fact, I'm honored to say that it's much easier in my clinic than any other bigger institute. Whatever the patient have told me, that if they go to MD Anderson, Sloan Kettering, or other places, they ask them to deposit 100,000 upfront.
Oh,
We will usually treat the usual fee, and if the patient can't afford, I will treat free as long as we have the access to the free medicine. But if there's our approved clinical trial, the medicine is always free. And we have some charity organization which even pays for the hotels to stay around. So if you are a foreigner, you have means to come to LA and Southern California, and I guarantee we will have a good weather for all of you. I can't guarantee a good Indian food. We will take care of you. So no restriction for me overseas or Canada or Mexico or South America or anywhere else in the world.
that is really good news. Okay, Kathleen Bain asks, if someone has a complete response to a trial, what type of maintenance is done to make sure there is not a recurrence?
Very good question. Those people who have remission, it's a good news. Unfortunately, significant number of them will relapse. So if there is no other trial available, I would put the patient on Pazopanib or Votrient, which is an oral drug, relatively non-toxic, to continue at least for a year. And if the patient doesn't relapse within a year, then chances of relapse go way down.
Oh, good. Okay. For metastasis to the lungs, would you start with Anamycin or Doxorubicin?
In fact, Anamycin people do require that somebody should have received Doxorubicin before Anamycin trial.
Oh, so you need Doxorubicin before you can take the Anamycin?
Yeah, but not too much.
But not too much, 6 cycles. Okay.
Yeah.
Can you discuss PARP inhibitors for LMS?
I personally do not have much experience with PARP inhibitors, nor I have done the trials, but I think it's reasonable to pursue some of the trials. Okay,
good. Yeah, we supported one with Dr. Sujona Mova at Memorial Sloan Kettering. She's doing a trial with PARP inhibitors. Let's see, we have another question. It's a little off topic. Is the survival rate for uterine leiomyosarcoma stage 4B very low?
You guys all know the answer, and I should not be commenting on that. Okay. But we will try to improve it.
We're going to improve it. That's what we want to hear. Okay, are they looking at any trials that address specific genes like the TP53, for example?
Yeah, number of these people are doing that. We had a trial, the drug which is AMG 650 against leiomyosarcoma. We only entered few patients, but the company has decided not to enter any more patients. They are more pursuing more lucrative diseases like ovarian cancer.
Okay, thank you. What is your opinion of DC vaccines, dendritic cell vaccine?
Overall future of immunotherapy is very good, and dendritic cell vaccine is a big future. At this point, there are lots of number of dendritic cell vaccine trials are going on, and hopefully some vaccines will come out which is more effective. At this point, nothing proven or nothing promising.
Okay. Have you heard of the Signatera testing, and what do you think of it?
I've heard of Signatera, and we are using Signatera testing, and it has been found very useful in some other cancers like bladder cancers. and we are doing in process of organizing a trial, how helpful it is, the circulating DNA to monitor the response. But I think the best utility of this is in the patient who have leiomyosarcoma. You did surgery, no evidence of disease, to decide whether they need adjuvant therapy or not, or somebody like you asked the question before, if they go in remission, and to monitor that.
Yes. Okay, I'm looking forward to that since I have yearly scans at 19 years out. Maybe I could do the blood test instead. Does it work to use Opdivo together with your Yervoy?
So we had the two drugs itself in some of the trials have not been found useful, but we did the trial, SAINT trial. We used Trabectogen, nivolumab, and ipilimumab, and we saw the best response frontline.
Okay, great. Thank you. Do you believe...
And that trial is still open as a frontline at our center.
At your center. Okay, great. We have another question. Do you believe in the future that the cancer vaccines that are currently developed will be a cure for LMS or recurrences one day?
I am sincerely confident we will develop. I pray develop that. Nobody could believe that a COVID vaccine can be developed in 1 year, and it did.
Right.
So I'm hoping that the cancer vaccine will come someday.
Okay. Is gemcitabine and docetaxel a standard first-line therapy for metastasized LMS?
I personally, the Gemzar docetaxel came in considering that it is less toxic. It is not really less toxic. It is as toxic as Doxorubicin or AIM. So I personally don't use that regimen. I will use metronomic doses of Gemzar, docetaxel, and Doxorubicin, all three drugs, day 1 and day 8. But if somebody wants to use it as a front line, I do not object to that.
Okay, great. So you're flexible. What's the best way to contact you to schedule a consultation?
Best is my office number, which is 310-552-9999. And if you have an emergency or need to talk to me urgently and my office ignored your call, call on my cell number, which is 310-500-5391.
Okay, I don't know a lot of doctors that give out their personal cell phones, folks, so take note of that.
My wife is very understanding, and we have been married over 50 years, and she encourages me to give my cell number. She says, God forbid, if anybody in our family had such problem, we'll like to have the doctor's number. So the credit goes to my wife.
Okay, we'll give her credit then. She puts up with all the phone calls all times of the day, and night. Let's see. Kathleen wants someone to spell out the name of the drug he mentioned if you are in remission.
It's called Pagopanib, P-A-G-O-P-A-N-I-B, or Votrient,
Or Votrient.
V-O-T-R-I-E-N-T.
Okay, great. Yeah, which drugs was it that can be used with Doxorubicin, not more than 6 rounds? That was Anamycin.
Yeah, so you should have received less than 6 Doxorubicin to be eligible for Anamycin trial.
Okay, here's an interesting question. Dr. Chawla, what sort of triggers?
So let's wrap it up. 2 more questions, and then I need to go.
Okay, all right. Dr. Chawla, what sort of triggers could activate a slow-growing retroperitoneal LMS tumor, slow for 5 to 10 years to become aggressive and metastasize?
GOK.
TOK, what's that?
No, G like GOK. God only knows.
Oh, GOK. God only knows. Okay. That's a scientific acronym, I bet. Okay, let's see if there's one more in here. Okay, let's see. Okay, here's a good one. Last one. Curious. Given your Indian roots, what are your thoughts about adding turmeric with gym tax? Where'd he go? Oh, I think we lost him. Yeah, he wasn't kidding. He meant one more. Maybe I can email him.
I still see him logged on as Ish Bhuya.
Did you hit the mute button by chance? No, it's not muted. Okay. Okay, well, we want to thank Dr. Chawla for spending his time with us. We know he's very, very busy. He gave us a lot of new options. Hopefully, we're going to write them down and get those notes out to people with the right spellings. And I thank you all for being here. Do you all